Hello everyone, I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about benign ovarian mass. So what we wanted to discuss today, the types of benign ovarian mass, whatever non-neoplastic or neoplastic one, the clinical presentation of the patients, the investigations needed, and if there is complication, what is this? What about it? Management of benign ovarian mass, and lastly, the recommendation for management by the Canadian Guidelines 2020. Okay, let us start with the classification of benign ovarian mass. Can be classified into two main groups, as you see here, non-neoplastic one and neoplastic one but benign. Okay, as you see in the picture, this is the uterus, this is the fallopian tubes, and this is the ovaries. We are talking today about the ovarian mass on the right or the left, whether it is non-neoplastic or neoplastic but benign one. Okay, so we are going to cover in non-neoplastic ovarian swelling, the functional ovarian cyst, the endometrioma, ectopic pregnancy, pregnancy luteoma, inflammatory cysts like tubal ovarian abscess, and polycystic ovary syndrome. As you see in the picture here, this is the chocolate cyst of endometrioma of the ovary. As you see, the dark brownish blood coming from the ovarian cyst here, called chocolate cyst. On the other side of this table, the benign ovarian tumors will be covered today. The benign mature cystic teratoma, as in this picture, with yellow capsule, and cystadenoma. And actually we have 5 types of cystadenoma: serous cystadenoma, mucinous cystadenoma, endometrioid cystadenoma, clear cystadenoma, and the seromucinous cystadenoma. And the third type of tumor is the fibroma, which is a benign also. Okay, so we have benign mature cystic teratoma, which is the dermoid cyst, and cystadenoma, and fibroma. This is as regard the benign neoplasm. In this picture, you can see categories of both non-neoplastic and the neoplastic benign. This is the functional cyst, this is the dermoid cyst, and this is the endometrioma, chocolate cyst, and this is the benign cystadenoma, and this is polycystic ovary. Okay, let us compare between non-neoplastic ovarian swelling, starting by the functional ovarian cyst, which may be follicular cyst, corpus luteum cyst, or cecal lutein cyst. Follicular cyst is the commonest one, okay, and they occur more with ladies who take induction for ovulation, okay, and also notice the follicular cyst in patients taking progestogen only pills. Corpus luteum cyst, the corpus luteum after ovulation is formed and become over distended with fluid, making a functional cyst, and may be complicated by hemorrhage, so-called hemorrhagic corpus luteum. Cecal lutein cyst, commonly seen with molar pregnancy and also in patients taking induction of ovulation and complicated by ovarian hyperstimulation and also received HCG. We will see cecal lutein cyst in this patient in molar pregnancy and in ovarian hyperstimulation syndrome after HCG injection. Okay? Mostly the function cysts resolve spontaneously, as we'll see. Endometriosis of the ovary, called chocolate cyst, the cyst filled with altered blood, so it is dark brown in color, and lined by epithelium resembling the endometrium. ectopic pregnancy. The ectopic pregnancy implanted in the ovary, and it accounts for 3% of all ectopic pregnancies, and has a clinical picture simulating tubal ectopic pregnancy with risk of internal hemorrhage. Inflammatory cyst may be oophorytis, tube-ovarian cyst, or tube-ovarian abscess as a complication of pelvic inflammatory disease on top of sexually transmitted disease or other infections. So, as in the picture here, bilateral tube-ovarian abscess. This swelling is the bilateral tube-ovarian abscess, right and left. And in the other picture here, this is ectopic pregnancy diagnosed by laparoscopy also. And in this picture here, this is the endometrioma or chocolate cyst of the ovary. Going to the pregnancy luteoma, which is a benign, not a tumor, but there is luteinized cell, usually ceca lutein cell, as you see in this picture, and it secretes androgen sometimes, causing virilization for the pregnant lady or her female fetus. Okay, our continuation with the non-neoplastic ovarian swelling, we said that the functional ovarian swelling mostly asymptomatic and discovered accidentally during ultrasound examination. Okay, also you should notice that it occurs in reproductive years. Yes, but maybe clinically presented by delayed menstruation or abnormal bleeding. May cause pelvic pain if complicated by hemorrhage, torsion, rupture. Cysts usually less than 10 centimeter and contain clear watery fluid with thin wall. And most of the functional cysts resolve spontaneously. Rarely it needs a treatment, and this treatment may be COC, combined oral contraceptive pills, for 1 or 2 months, or maybe if it has a larger size, we can do laparoscopic cystectomy, or if complicated by torsion also, we should interfere surgically either by laparoscopy or laparotomy, but laparoscopy is the preferred procedure. So, most of the functional ovarian cysts will resolve spontaneously without interference. What about the endometriosis? Endometriosis commonly associated with chronic pelvic pain, dysmenorrhea, infertility. The characteristic endometrioma has a thick wall, not like the functional cyst thin wall. Here is a thick wall with altered blood content. So give the brownish color of the fluid content of the cyst. Usually less than 10 centimeter, frequently bilateral, usually associated with pelvic adhesions and endometriotic deposits in the pelvic peritoneum and pelvic organs. Ectopic pregnancy will simulate the tubal pregnancy with positive pregnancy test, empty uterine cavity, and adnexal mass, and if ruptured will cause internal hemorrhage and needs an emergency interference by laparotomy and excision. If the patient hemodynamically stable, we can do it by laparoscopy. Tube ovarian cyst or abscess is a complication of PID on top of sexually transmitted disease or other infections associated with severe pain in the abdomen, tender cervical motion, and history of previous sexually transmitted disease, maybe, or ID insertion. Management of tube ovarian abscess is an emergency situation, needs drainage for the tube ovarian abscess, laparotomy and drainage, and serpingiorectomy may be needed. Okay. Pregnancy luteoma, usually asymptomatic, and discovered accidentally during ultrasound or during doing cesarean section for delivery, we discover the pregnancy luteum. You can see it bilateral. Commonly, it is a solid mass measuring 8 to 15 centimeter, has a yellow or gray color on cut section. As we said before, may cause virilization due to androgen secretion and regress after delivery. What about PCOS, Polycystic Ovarian Syndrome, which was called in the past Stein-Leventhal syndrome? This is a complex endocrine disorder characterized by menstrual abnormalities, oligomenorrhea or amenorrhea, hyperandrogenism, either clinical or lab evidence, polycystic ovary morphology by ultrasound, as you see here in the picture, with necklace appearance. You can see many follicles here, measuring 2 to 9 millimeter, and the number of the follicles must exceed 20 in each follicle, in each ovary, as mentioned by modified Rotterdam criteria 2020. So we can diagnose PCOS if we found 2 out of 3. Amenorrhea or oligomenorrhea, clinical or lab evidence of hyperandrogenism, and ultrasound morphology of PCOS in the form of number of follicle more than 20 in each ovary, size of the follicle between 2 to 9 millimeter, and volume of the ovary more than 10 centimeter. Okay? This is a picture by laparoscopy. As you see, the macroscopic picture of the ovary looks enlarged to nearly may reach twice the size of the normal ovary, with thick, glistening, smooth capsule, as you see here, cortex, as you see here. There is no corrugation, just a smooth, thick, whitish capsule like gauze egg. Okay? So this is the picture by laparoscopy, and this is the picture by transvaginal ultrasound. So what about the benign ovarian tumors? Benign ovarian tumors usually grow slowly and rarely become malignant. And actually we have 3 benign ovarian tumor. Dermoid cyst, which is a benign mature cystic teratoma derived from germ cell tumor, and from the 3 germ cell layer, the ectoderm, mesoderm, and endoderm. Cystadenoma, and we have 5 types of cystadenoma: serous, mucinous, endometrioid, clear cell, and seromucinous one. And fibroma, which is a slowly growing solid ovarian tumor, benign, and usually less than 7 centimeter. And to understand this benign ovarian tumor, you must remember the classification of ovarian tumor by WHO and FIGO. They divide all ovarian tumors, benign and malignant, into these categories: surface epithelial tumor, the commonest; germ cell tumor; sex cord stromal tumor; mixed ovarian cell tumor; non-specific and unclassified tumor, and secondaries. What belongs to us in our lecture today is the benign only. Okay? The benign of the surface epithelial tumor is cystadenoma with its 5 types, as I mentioned before. The benign of germ cell tumor is the dermoid cyst or benign mature cystic teratoma. The benign of sex cord stromal tumor is the fibroma. Okay, this is the common benign ovarian tumors. As you see in this picture, this is a picture of the ovary to show you the origin of this tumor. either from epithelium, ceromic epithelium, on the surface here, or from the germ cell, or from the stroma or six-cord granulosa cell here. Okay, so this is the six-cord stromal, and this is the germ cell, and this is the epithelial tumor. Let us go to the mature cystic teratoma, which is a very common neoplasm, and we can say this is the commonest ovarian neoplasm and the commonest benign neoplasm. Account for 60% of all benign ovarian neoplasm. Typically around the age of 30, but this is the commonest also ovarian neoplasm in women younger than 20 years. If uncomplicated, it is asymptomatic and discovered usually accidentally by ultrasound, as in this picture. This is dermoid cyst discovered by transvaginal ultrasound. You can see it bilateral in 10 to 15% of cases. The diameter range usually between 5 to 10 centimeter, rarely to exceed 10 or 15 centimeter. It has a long pedicle, and this long pedicle is liable for torsion. That's why dermoid cyst is liable for torsion, and this is one of the complications of benign ovarian neoplasm. And because of the long pedicle, you can see the ovarian dermoid cyst anterior to the uterus because of this long pedicle. Usually we see the ovarian cyst either at the nexal or in the Douglas pouch or abdominal, but anterior to the uterus occurs due to long pedicle of the dermoid cyst. It is composed of 3 germ layers, as we said before: ectoderm, mesoderm, and endoderm. That's why the content of the cyst, as in the picture up here, may be hair, sebaceous material, tooth, cartilage, bone, fat, nails, teeth, eyes, or thyroid tissue. So, any ectoderm or mesoderm or endoderm organs can be seen inside the dermoid cyst, but commonly the ectoderm predominate. Okay, and the doctor who discovered first call it dermoid cyst because he suggested that it is of ectoderm only because of the hair and the skin. But when they discovered later on that it contains others than ectoderm, endoderm, and the mesoderm, okay, they call it mature cystic teratoma, benign mature cystic teratoma, and this is the right name for the dermoid cyst, the more scientific name. Ovarian cystadenoma, as we mentioned before, we have these 5 types. Let us go to each type. Ovarian serous cystadenoma develop as hyperplastic extension from epithelial inclusion, and most serous cystadenoma are polyclonal, but monoclonal cystadenoma occur. Don't have mutation in either KRAS or BRF gene. It accounts for 60% of ovarian serous tumor, so it is the commonest in serous tumor. They are the commonest type of ovarian epithelial neoplasm also. The peak incidence around the age 40 to 60 years, and usually asymptomatic, except if reaching larger size, the patient may feel pelvic heaviness, pelvic pain, clotting, or discomfort. Otherwise, usually discovered accidentally during ultrasound examination or during BV and bimanual examination. What about the ovarian mucinous cystadenoma in comparison to the ovarian serous cystadenoma? The association, you should know this point, because the origin of ovarian mucinous cystadenoma is controversial. Why? Because it was noticed that you can see a case with mucinous cystadenoma with dermoid cyst. And you can see, and this indicating it is of germ cell origin. And also on the other side, you can see mucinous cystadenoma with Brenner tumor. And the Brenner tumor belong to epithelial ovarian tumor. So it is of epithelial origin. So whether it is of epithelial origin or germ cell origin, it is a controversy because both of them noticed, both situations noticed in cases with ovarian mucinous cystadenoma. What about the gene KRAS mutation? It is present in 58% of cases. Okay, what about the incidence of ovarian mucinous cystadenoma? 80% of mucinous ovarian tumor are ovarian mucinous cystadenoma. Okay, so 80% of mucinous ovarian tumor and the 20% of all benign ovarian neoplasm. Okay, what is the commonest age? Between 30 and 60. What is the clinical presentation of the patient? Usually also asymptomatic as ovarian serous cystadenoma, except if reaching large size or complicated. The same like pelvic discomfort, abdominal bloating, and pelvic pain, or symptoms of complications. Let us go again to the ovarian serous cystadenoma. It is bilateral in 15%, while the mucinous is rarely bilateral, 2 to 5%. Let us go to the macroscopic picture and the microscopic picture. As regards the ovarian cystadenoma, has a smooth surface, soft, and composed of unilocular, but maybe multilocular cyst, filled with clear watery fluid. The lining of the cyst is flat or contain papillary projections, small papillary projections. And the cyst measure on the average 10 centimeter in diameter, but may be larger, can reach larger size. The microscopic appearance composed of cyst and papillae lined by non-stratified or stratified cuboidal or columnar cells resembling fallopian tube epithelium. What about the ovarian mucinous cystadenoma? The macroscopic and the microscopic picture. It has a smooth outer surface, soft in consistency also, and usually multilocular, and it contains mucinous fluid. The size may be ranging from few centimeters to more than 30 centimeters, so it can reach a huge size. Microscopic appearance composed of multiple cysts and glands lined by simple non-stratified mucinous epithelium resembling gastric foveolar type or intestinal epithelium containing goblet cells, and sometimes neuroendocrine or panethels. And ovarian stroma may be cellular with areas of stromal luteinization. This is how it looks, the ovarian serous cystadenoma with a smooth surface. Okay, and this is the mucinous cystadenoma, how it looks, with many locules containing mucin. What about the endometrioid cystadenoma? The morphological and molecular genetic study have implicated endometriotic cyst and endometriosis in the development of endometrioid, clear cell, and seromucinous tumor. So, all three types, endometrioid, clear cell, and seromucinous, related to endometriosis origin. Endometrioid epithelial tumor account 2 to 4% of all ovarian tumors. They usually occur in the fourth and the fifth decades. The cysts range in size up to 15 centimeter. The cyst lining is irregular with areas of hemorrhage. Cyst contents are typically dark brown due to old hemorrhage, simulating that of shackled cyst, if you remember endometrioma. What about the histopathology? Similar to endometriotic cyst, but lack endometrial stroma, hemocidral-laden macrophages, and myofibroblastic wall. This is how endometrioid cystadenoma look. Please look to the altered dark brownish blood like endometrioma. That's why we said it is of endometriosis origin. And also endometriotic patches here. You can see the cut section here. So this is the endometrioid cystadenoma. What about clear cell cystadenoma? It is very rare actually, and few cases reported. Macroscopic finding: clear cell cystadenoma range in size between 3 to 16 centimeter, smooth outer surface, lobulated. The histopathology of clear cystadenoma, it is composed of glands or cysts lined by cuboidal or flattened cells with clear or eosinophilic cytoplasm embedded in fibromatous stroma. There is no cytological tibia and no mitotic figure. What about seromucinous cystadenoma? Also, it is related to endometriosis. Its origin coming from endometriosis. And recent molecular studies also suggest that this particular tumor is a variant of endometrioid tumor. So recently they are suggesting that it is a variant, not a separate entity, but it is a variant of endometrioid tumor. Occurs in adult with peak in the late reproductive age group at the age of 40. Macroscopic finding: it is a unilocular cyst with a smooth surface and the inner lining, may contain serous or mucinous fluid, frequent involvement of both ovaries, between 20 to 40% bilateral. The cysts are lined by endocervical type columnar cells with abundant intracytoplasm of mucin, but they're also available at mixture of ciliated cells, endometrioid cells, and less often transitional or squamous cells. This is how it looks. This is the seromucinous cystadenoma. And if you see the cut section, you can see endometriotic spots or patches also, denoting endometriotic origin. What about the Pseudomyxoma peritonei? Actually, it is a unique and extremely rare clinical syndrome with an estimated incidence 1 or 2 per million per year, characterized by extensive intraperitoneal mucinous effusion resulting from accumulation of gelatinous ascites or disseminated lesions of neoplastic mucinous epithelium. What is the etiology? Many years before, in the past, we are suggesting that it is related to ovarian mucinous cystadenoma is the cause of Pseudomyxoma peritonei. But actually, it is the primary site for this complication is the appendiceal mucinous cystadenoma. And many gynecologists believe that the mucinous cystadenoma, even on the ovary, is coming from the appendiceal mucinous cystadenoma, which is the primary site of this tumor. So we can suggest that most of the Pseudomyxoma peritonei related to the appendiceal mucinous cystadenoma, not the ovarian mucinous cystadenoma. Even the ovarian cystadenomas itself may be secondary to appendiceal 1. And of course, it can occur primary of ovarian origin derived from endometriosis, as we mentioned before. Let us go to the ovarian fibroma, which is a benign solid ovarian tumor related to sex cord stromal tumor classification of WHO, as you remember. Accounts for 4% of all ovarian neoplasm. They are the most common sex cord ovarian tumor. Occur at all ages, but more common in middle-aged women. Generally asymptomatic and discovered accidentally during ultrasound examination or by manual examination, confirmed by ultrasound or MRI. Associated with ascites in 40% of cases and with pleural effusion in a small percent of cases. And this is what's called Meigs syndrome, ovarian fibroma, ascites, and right pleural effusion. Fibroma have no cecal cells, but may have little fecal cells, and may be functioning or non-functioning, and if functioning, minimal functioning with estrogen activity. It is composed of spindle cells forming variable amounts of collagen, sectioning of fibroma typically simulating fibroid of the uterus with whorly appearance in the cut section. Areas of edema and cyst formation is common. So what is Meigs syndrome? In 1937, Joe Vincent Meigs and John W. reported 7 cases of ovarian fibroma, ascites, and pleural effusion. That's why the criteria to diagnose Meigs syndrome should fulfilling the following: presence of benign tumor of the ovary, either fibroma, sarcoma, or granulosa cell tumor or Brenner tumor. Presence of ascites, presence of pleural effusion, and lastly, and what is very important, is the resolution of the ascites and the pleural effusion after you do excision to this ovarian fibroma. Must be happen. Resolution of the ascites and the pleural effusion. Okay? Ovarian fibroma constitute the majority of benign tumor seen in Meigs syndrome. So most of the Meigs syndrome are ovarian fibroma, not the other categories. We diagnose Meigs syndrome by exclusion. Specifically, we should exclude the malignancy because presence of ascites may be a sign of malignancy. Presence of pleural effusion may be a sign of metastasis of ovarian malignancy. So we should do our best to exclude malignancy first, then we diagnose Meigs syndrome. About 1% of ovarian tumors present as Meigs syndrome, and as I said before, a similar presentation can be seen in many metastatic malignancies. So you should exclude malignancy. So let us speak about the benign ovarian mass. What is the clinical presentation of this mass? Whatever it is, non-neoplastic, like functional cyst, endometrioma, tube ovarian abscess, pregnancy luteoma, okay, PCOS, or neoplastic like fibroma, like dermoid cyst, like Serous Cystadenomas or mucinous, and so on. So what is the clinical presentation of all these benign masses? Most functional cysts and the benign tumor are asymptomatic, as we mentioned before, but some functional cysts may be associated with menstrual abnormalities. Hemorrhagic corpus luteum associated with pain or signs of peritonitis, particularly after rupture of the cyst. Specific symptoms and signs related to endometriosis like pelvic pain, infertility, dysmenorrhea, tenderness and the nodular uterosacral ligaments, adnexal mass, which is tender, dyspareunia. So all this related to endometriosis. Ectopic pregnancy may be presented with the ovary, may be presented with adnexal mass pain, and maybe sudden severe pain and symptoms of internal hemorrhage. And this is an emergency situation due to rupture of the ovarian pregnancy. Sometimes benign mass presented by symptoms of complication like torsion, like infection, like rupture, and so on, especially if this benign mass exceeding 4 centimeters. Ascites and rarely pleural effusion may accompany fibroma, as we mentioned before. What is the investigation needed? Simply, you should do pregnancy test to exclude ectopic pregnancy first. You can do tumor marker like CA125, which is the commonest one because it is related to the epithelial ovarian tumor, which is the commonest one. Okay, so that's why if you will ask for one tumor marker, ask for CA125. There is commercially available 5 tumor markers: beta-2 microglobulin, cancer antigen 125, apolipoprotein A1, prealbumin, and transferrin. What is the significance? May help in determining the need for surgery. And you should know the differential diagnosis of elevated tumor markers, like because it may be elevated in different situations, like uterine fibroid, peritonitis, cholecystitis, pancreatitis, and inflammatory bowel disease, and of course with endometriosis. Imaging studies. Is there a rule of imaging? Yes, of course. And the first to be used or done is the pelvic ultrasonography and the abdominal ultrasonography. It is available tool, so you should use ultrasonography first, and you can diagnose many of the benign ovarian mass by ultrasound with the other signs and symptoms of the clinical presentation of the patient. Okay? If you still in query, you can do CT scan or MRI. The features that are more suggestive of benign cystic neoplasm include: by ultrasound, if it is unilocular with thin wall, no papillary projection, no ascites, and the negative lymph nodes. This is the signs by ultrasound to say this is a benign lesion. As you see in this picture, this is functional cyst, unilocular, sonolucent, clear fluid inside. While in the other picture here, the fluid is turbid, little turbid, and hyperechogenic pool here, because this is a dermoid cyst containing specious material and hair and so on. So this is a dermoid cyst and this is a functional cyst, but both of them is benign. What is the complication of ovarian tumor? As you see in this picture, torsion of the adnexy, and this is very important, and this is an emergency situation. Or maybe hemorrhage inside the cyst, or rupture and internal hemorrhage or infection or incarceration, the pelvis, or pregnancy complication if associated with pregnancy may cause hazards on the pregnancy, and the pregnancy itself may cause hazard on the cyst, like in this case, she was pregnant and this is torsion while during the pregnancy. So both of them can affect the other, the cyst and the pregnancy. Meigs syndrome, and lastly, if malignant transformation happens. Let us go to the management of benign ovarian mass according to the Society of Obstetricians and Gynecologists of Canada 2020. What is your target population? Women above 18 years of age presenting for evaluation of an ovarian mass, simple unilocular cystic mass, or endometrioma, or dermoid, or fibroma, or hemorrhagic cyst, who are not acutely symptomatic and without known genetic predisposition to ovarian cancer. The following ovarian masses typically demonstrate classic benign feature on ultrasound, as we mentioned before: simple, unilocular, thin wall, cystic, also the hemorrhagic corpus luteum cyst, endometrioma, and the mature cystic teratoma with its characteristic features, and fibroma. The risk of malignancy for simple ovarian cyst is rare, less than 1% for cyst less than 10 centimeters in diameter. Patients with an ovarian mass more than or equal to 5 centimeters in diameter are at increased risk of ovarian torsion. It can happen, yes. Laparoscopy is the recommended approach for surgical management of symptomatic benign ovarian mass. Technically feasible, safe, but also provide the advantage of shorter hospital stay, faster recovery time, and less pain and bleeding compared with laparotomy. As you see this picture, the ovarian cyst here diagnosed by laparoscopy and can be managed in the same set during laparoscopy by either ovarian cystectomy or oophorectomy accordingly. Comprehensive preoperative evaluation is necessary in order to determine the risk of malignancy of an ovarian mass before deciding on the appropriate surgical management. This is very important. You should exclude malignancy. Electrocautery for hemostasis during laparoscopy, as in this picture. You should use the electrocautery in a wise manner. Be wise during cauterization, so not to damage the healthy tissue of the ovary. So this is very important also. So what is the recommendation by SOGC 2020? In a symptomatic patient, masses characterized as a benign on ultrasound can be followed initially by repeated ultrasound. So we can repeat the ultrasound after 8 weeks or even 12 weeks during the proliferative phase. So you ask the patient to come after menstruation, immediately after menstruation, and do ultrasound for her. Then this is for the premenopausal women in childbearing age. Then follow up by ultrasound can be done yearly for masses that remain stable and don't develop malignant feature or complications. Most asymptomatic mass less than 10 centimeters in diameter and characterized as a benign can be managed conservatively. If surgery is performed for symptomatic mass which is benign, unilateral or bilateral oophorectomy can be considered for postmenopausal women, and ovarian cystectomy can be considered for premenopausal women. So if you are facing this situation with symptomatic mass, benign mass, will look to the age. If the lady is post-menopause, it is better to do unilateral or bilateral operation. If the lady is pre-menopause, you can do conservative surgery like ovarian cystectomy. For perimenopausal women, the decision to perform cystectomy with possible salpingectomy versus an oophorectomy should be part of shared decision making discussion between the patient and her health care provider. Okay, here we have a lady with a benign mass in a perimenopause age. Okay, okay. The question here to do cystectomy and the salpingectomy. Look to this picture, please. Like this ovarian cyst, I can do cystectomy and remove the residual ovarian tissue. With cystectomy, I will do salpingectomy also. Okay? Okay. Why I'm leaving the residual ovarian tissue? To give her the hormones till the age of menopause. Okay? The comparison here between cystectomy and salpingectomy or oophorectomy. I remove the ovary with cyst. You will ask me why you said cystectomy and the salpingectomy in one side. Salpingectomy because sometimes the source of ovarian malignancy, especially in serous carcinoma, commonly related to origin from the fimbrial end of the fallopian tube and the serous intraepithelial nucleus. So when you are going to do cystectomy in a perimenopause age and you do salpingectomy, this is one decision, or you are doing oophorectomy, remove the whole ovary, and you should discuss this with the patient. Laparoscopic ovarian cystectomy is the recommended surgical approach for ovarian cystic mass rather than fenestration and aspiration. Of course, you should excite the cyst, not just aspirate the cyst or fenestrate the cyst. You should do excision of the cyst. Why? Because it will be recollected again and recurrence of the cyst again. Laparoscopic management should involve examination of peritoneal surfaces, appendix, upper abdomen, posterior cul-de-sac, bladder, in addition to the uterus tubes, ovaries, for evidence of disease, in addition to pelvic washing for cytology, and the biopsy of peritoneal surfaces should be taken for histopathology only if malignancy is suspected. This is very important. Peritoneal washing for cytology and frozen section for analysis should be undertaken at the time of surgical management of ovarian mass if there is suspicion of malignancy. If you are going to do operation for a lady and you are diagnosing her as a benign ovarian mass, then during laparotomy you were surprised by signs suggesting malignancy. What you are going to do? You are going to do staging laparotomy, do inspection to the pelvis, abdomen, pelvic organs, omentum, intestine, diaphragm, lower surface of the diaphragm, liver, spleen, any lymph nodes enlargement, do peritoneal wash, and send for cytology, take a biopsy from the mass for frozen section. So it is very important to be ready to do this staging laparotomy or all details what I said right now. When the pathology results reveal malignancy in an ovarian mass that had originally been assumed benign, was diagnosing the case as a benign ovarian mass, then the condition during laparotomy revealed it is a malignant one. Comprehensive surgical staging should be performed, as we mentioned, with expertise in gynecologic oncology if resources permit. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.